What about vulnerability assessment? Who's doing that?
Vulnerability assessment can be a perspective or really a lot of classifications within inside the facility. However, due to the elements that are assessed during the process, H-1 staff are not eligible to participate in that audit.
Okay. You also talked about, and I'm just picking these out, there were a number of things that you were talking about, but you also talked about security analysis. Who's doing that?
I guess I need to clarify whenever I say H-1, because correctional trades instructors such as electronics trades instructors, they are heavily tasked in the participation in vulnerability and security analysis processes. They are required, in some cases up to 2 ETIs are required to participate in the processes for VA and SA, and that is because that is where the subject matter expertise lies for the assessment of the functionality of our perimeter intrusion detection system.
Okay. And I just asked you, and before you went to clarify that, I talked about the security analysis. Who's doing the security analysis that you referred to?
Once again, that is members of management along with staff, such as an ETI is required to serve on every SAT team. Okay.
So is it fair to say that when you're doing facility security statewide, you're trying to implement all these techniques that you're using to secure these facilities? A lot of the analysis is done by management, is that correct?
Yes.
But when it comes time to getting the bulk of the actual work done, whether it's doing urine analysis, whether it's doing any type of implementation of these policies that are generated, is it the H-1 membership that's doing the implementation of this?
They complete the work.
Okay. And you started in Smithfield in 1995, is that correct?
Yes.
And did you start as a CO?
Correctional officer trainee.
Trainee, okay. So in the last 16 years, you've moved up to the rank of major, correct?
Yes.
All right. And would you agree with me that at least over the last 16 years and through your analysis that you've presented here today, that the knowledge, the skill that a correction officer faces today has increased over the last 16 years?
I think the technologies and policies and procedures in place have required them to change with the time.
Okay. Well, I thank you very much. I think you have presented this, the arbitration board with a clear understanding of how much training and how much knowledge a CO has to acquire and use on a day-to-day basis. So thank you.
Any questions from Tom? Just one clarification question. For example, in the staffing surveys, can the correction officers participate in the process?
Yes, the union is offered a chance to participate in the process. They, of course, get their injects into the staffing survey process. They are permitted to participate in the actual site visits, and they can tour with the staffing survey team throughout the process while they're conducting their site visit.
Thank you.
Thank you, Major. Thank you, Major.
I think that's much. She's only going to go for 8 minutes.
We're going to go off the record for a second. Okay, we're back on the record. Commonwealth ready to present its next witnesses.
Yes, this will be our last presentation for the afternoon.
Okay.
To my right at the panel, we have Tracy Cannon from the Norristown State Hospital. She is a forensic nurse manager. To her right is Patricia Kaufman, a forensic nurse manager out of Torrance, and Marcy Hepner, who's the chief forensic executive at Torrance.
Welcome. Mr. Shell.
Good afternoon, and thank you for the opportunity to share with you some of our background and our experiences within the Department of Public Welfare system. A little bit of background about myself. I'm fairly new to the system and nowhere near as experienced as my counterparts in the Department of Corrections that have spoken before us. Patty and I both were part of the Mayview transition in 2008. We were asked to be part of a transition team to be assigned to the Mayview State Hospital Regional Forensic Psychiatric Center and assisting with relocating that facility to Torrance State Hospital. Through that experience, the opportunity to become the chief executive before the forensic unit became available, for which I applied and was awarded the position. Prior to that, I had been the Chief Performance Improvement Executive at Torrance State Hospital, and prior to that, I had been the Quality Assurance and Risk Management Coordinator for Torrance State Hospital as well. And that all occurred since 2004. In the years prior to that in my career, I was not a state civil service. I was not a state civil service employee, however, was working in local government civil service for a county MHMR program for a number of years. So I'll direct you to our slides, and then we'll go from there. So the first slide was relating some experience about our forensic security employees. Our systems are the state mental hospitals under the Department of Public Welfare. We are regional forensic psychiatric centers, and there are only 2 in the state now. In the early 70s, there was a partnership between the mental health providers under the Department of Public Welfare and the legal system to determine how we would be in compliance with the Mental Health Procedures Act. As a part of that, the regional forensic psychiatric centers were put into place. And through the course of time, eventually the security employees were developed as a hybrid between the psychiatric aid of the civil side of the hospital and the corrections officer and a Department of Corrections type of facility. So we have a hybrid type of position under state civil service that is referred to as an FSE, forensic security employee. All of our FSEs are considered part of the H-1 bargaining unit, and those members provide mental health services in a therapeutic environment. That environment is a hospital setting. So our next slide, the one prior. I do want to emphasize that we are state mental hospitals. They are hospital healthcare settings, and they are all under the Department of Public Welfare, under the Office of Mental Health and Substance Abuse Services. So our mission statement is quite different from that which you saw under the Department of Corrections earlier today. You can read for yourself, but as you're reading, some of the things that impacted our services and our development over the time since the early 70s, as you can see, for all of us, the system and the world itself has changed dramatically. We've gotten much better, we've gotten much more intricate in how we measure our success and how we gauge our business and what our responsibilities are in that sense. In 2003, the mental health systems started a major reorganization. The president himself had put out a new Freedom Commission on mental health services and what we were all to do in order to comply with that. The Department of Public Welfare in Pennsylvania provided a blueprint for what our changes should be and how we should focus our future efforts. We believe that with the right supports and access, people, men and women, who receive services in our systems can and do recover, that they have every right and opportunity to have a quality of life within their own community. And with that, we also acknowledge that we receive a lot of recognition for those negative events that occur sometimes by people that are served either within the correction system or within the communities. Oftentimes, we're given an awful negative image based on the actions of one person. Department of Public Welfare has a vision for a holistic approach to recovery. We've expanded our infrastructures to address target populations and their priorities. The forensic population is one of our target populations within the Department of Public Welfare. So you may ask, what exactly is a forensic unit? Well, the forensic units were established as specifically defined by the Mental Health Procedures Act. There are some very distinct points that have to be considered. They were established to ensure that the intent of the Mental Health Procedures Act is fulfilled by providing inpatient psychiatric evaluation and treatment as ordered by the courts while ensuring that criminal detention is maintained. Department of Public Welfare then looked at the legal system and decided that it really was necessary to create some type of program to be able to pursue and fulfill these requirements. So the requirements of the Mental Health Procedures Act establishes rights and procedures for all involuntary treatment of mentally ill persons. This is directly quoted from the Act. specifically provides that in every case, the least restrictions consistent with adequate treatment shall be employed, and defines adequate treatment as a course of treatment designed and administered to alleviate a person's pain and distress and to maximize the probability of his or her recovery from mental illness. Statewide, within the state mental hospitals, we have a quality assurance and risk management priorities. We have policies, we have specific indicators that we look at, and we are a national benchmark that we utilize in collecting that data and analyzing it, looking at it for weaknesses, strengths, and areas that we can use to determine our next priorities and opportunities for improvement. We're also required to do so by the Joint Commission and the Centers for Medicare and Medicaid Services. They are both accreditation bodies, and they both determine some of the standards by which we operate. We promote promising, evidence-based best practices within our systems, and we certainly look at the least restrictive environment to provide those services across the board. Within the hospitals, there's a process defined by the CEOs to determine performance improvement initiatives within every single department. Within our specific buildings, we have to pay attention to details such as much more freedom of movement, the opportunity for people to have choice with their treatment and their future and the direction that their lives are going, knowing full well that they have criminal charges pending. We're looking at unified practices across the state so that when we receive services in one facility, they will be exactly the same in an alternate facility. We look at recovery, and we hope that people continue to have hope for their own future, whether it be time served in a community much like we all live in, or time served in a community within the four walls of a prison. There are 2 regional forensic psychiatric centers, as I mentioned before. Those centers being Torrance State Hospital, which is in Blairsville, or just outside of Blairsville, outside of Pittsburgh, Pennsylvania, in the western part of the state, and then Norristown State Hospital is the other. As you can see, our total complement at Norristown is 159 FSEs, for a total forensic patient population of 127 out of 135 beds available. At Torrance State Hospital, at the Regional Forensic Psychiatric Center, the total FSE complement is 125. Our patient population is 78 out of 100 currently being utilized. Each of the forensic centers has 1 unit designated specifically for women. The rest of the units are for men. Norristown has 6 total units, with 1 of those units being for women. Torrance has 4 units, 1 being for women. So who do we serve in our forensic units? We serve people with a mental illness or perhaps a mental illness who've been charged with a crime and are court-ordered under one of the following circumstances. They may be incompetent to stand trial, and the judge is asking us to determine whether or not they can be restored to competency. They may be not guilty by reason of insanity. They may be with us pre-sentencing for an evaluation. We may be asked by the judge to offer some assistance with aid in sentencing when we have complicated multi-systems, maybe mental health, mental retardation involvement, perhaps addictions, perhaps a whole host of other abilities, disabilities, and systems involvement that presents a very complex case, as you're familiar with. Or the person may be in need of treatment and meet the criteria for commitment and involuntary treatment. There are specific grounds that need to be met to qualify for involuntary treatment, while maintaining a secure environment. So we provide all of those things while maintaining a secure environment. Generally, the patients that come to us, and I did say patients, not inmates, are coming from the county level correction system. It is more outside of the realm of our typical service to receive somebody from the state correctional facilities. Once they've been sentenced, generally they go to the state correctional facilities. Our patients are from the county level, generally. Our goal is to provide treatment and restoration as a service to the courts.